This is everyone then?
This will be everyone for today.
Okay.
Yep. There might be one straggler or two.
Okay. Like Rachel said, my name is Jonathan. I'm one of our surgical neurophysiologists here. We have a team of 5 of us. Brian Arrigo, our director, is here to join us.
Hey.
I know most of you have met a couple of our other colleagues, Keith Bartos and Ben Lee. We had someone recently join our group from Pittsburgh. Her name's Cameron. So if you guys see her, she's the only female in the department, so pretty easy to distinguish who's who. But I'm sure you'll get some FaceTime with everyone as you guys start doing more clinicals. I've been with this group here for about 4 years now. 4 years? Years 4. Been doing this for about 7 years. Used to work here at Hammett as an anesthesia tech, and then left to pursue this career. So if you guys ever need some help, I'm in your room.
That is a big offer to me.
Yeah, that was bold. That was bold. That was bold.
So some of the, some of the CRNAs already utilize me a little bit, because they know that I used to work here. But yeah, I'm happy to help you guys out if you need some help. As long as it's not in, right in the middle of surgery where I can't, get up and assist you. But I'd be happy to help out. That's pretty much, my life story. Didn't really have any intention of joining. I didn't even know about this field when I worked here as an anesthesia tech. I actually got into it talking to Brian over here, and he kind of introduced me into the field, and here I am. The rest is history. So we're kind of our own niche. Not many people know this, that IOM exists. But today's lecture, we're going to be going over a little bit about what we do on a day-to-day basis in the OR, and cases we do, the modalities we offer to the surgeon, and then most importantly, how anesthesia kind of plays in a role and can either affect our signals, amplify them, or the complete opposite, which we don't like sometimes. But. Okay. Okay. So what we do, we run what's called intraoperative neuromonitoring real time during surgical procedures. This is used to protect the central and peripheral nervous system from injury. During procedures such as spinal decompression or fusion, that can result in spinal cord injury, nerve root injury, functional mapping of the brain and the spine, cardiovascular procedures, not so much here. The only really vascular procedure that we're involved with at the time here is carotid endarterectomies, but we have the ability to monitor any open heart surgery or any cerebral procedure where they're going, or cardiovascular procedure where they're going on circulatory arrest. Oh, sorry. Or any procedure that carries risk to cranial nerves that arise from the brainstem. And it's performed by us in the OR, and then we have a neurologist on all of our cases, so they're doing all the interpretation, and we're communicating real time with them. So we have anywhere between either 1 or 2 of them on all of our procedures. Some of the modalities that we use on a day-to-day basis, SSEPs, which is what we're referred to in most rooms as SSEP. This stands for somatosensory evoked potential. We can do brainstem auditory evoked potentials, transcranial motor evoked potentials, visual evoked potentials. Excuse me. electroencephalography and EMG, so that includes the spontaneous and the triggered EMG. So the triggered is when we would stimulate with the probe, either pedicle screw testing or direct nerve testing. Okay, grade confrontation. So these modalities that we use in the OR, you know, this kind of, I put this slide in the grade confrontation because a lot of what we do, the drugs that you guys administer can affect our signals. Obviously, we need to keep the patient asleep with general anesthesia, so that involves reversible loss of consciousness, amnesia, analgesia, paralysis, which requires suppression of the nervous system. So this creates a physiological confrontation. So to provide optimal patient care, we need to have really good communication and cooperation with you guys. So the role of us in the OR, the IOM team, is to alert the surgeon when there's significant changes in our data from the baseline values that we establish at the beginning of the procedure, which would indicate impending loss of function. So some examples of what these changes could be caused from would be surgical maneuvers, ischemia, positioning of the patient, and if we can detect it, when we detect these changes, sometimes they can be reversed, sometimes they can't. But some of the changes are can be mimicked by anesthetic agents. So it kind of makes it difficult for us to diagnose what was occurred, depending on if it's a focal change or a global change, and whether or not we're communicating as far as what you guys are doing at the head of the bed, as far as drugs administered, boluses, if you're giving paralytic, etc. So what do these agents do to our monitoring? We know that anesthetic agents work in the nervous system by altering the neurological or the neuronal excitability via changes in synaptic function or axonal conduction. So the size, the effect that the agent has on the IOM modality increases with the number of synapses present on the pathway that we're monitoring. So essentially, more synapses, it's more sensitive. So we're going to go into some of those modalities here, and we're going to give some examples of some changes here. The first one we'll review is EEG. So this is electroencephalography. It's a measurement of the electrical activity produced by the brain, recorded from electrodes placed on the scalp. So you can see a picture here. These are just some surface electrodes placed on this baby here. And what we do for EEGs, we record voltage on the y-axis and time on the x-axis. And this can be used to identify decreases in cerebral blood flow states. And it can also be used to identify intra-op seizures. So here's a picture of what a intra-op seizure would look like here. So the EEG activity is a product of multisynaptic activity, and it's very sensitive to certain agents. So these agents would be your volatile inhalation agents, your barbiturates, propofol, and benzodiazepines. So why do we think that these drugs would be, would have an effect on EEG?
Slow.
It's hyperpolarizes.
Hyperpolarizes, right? So these are all essentially GABA A. They're inhibitory, right?
Mhm.
Yeah. So this is an example of a real change. So you can see in the EEG over here, the blue traces here, these are all left hemisphere. These red ones are right hemisphere. And these montages here, this like F3, P3, these just correlate to specific sites on the scalp that we're recording from. But we can see this kind of isoelectric or minimal, there's minimal activity here. And if we look over here on our DSA, we can see a shift in power. So it's an inward shift. We can see all this dark segment here is indicating that there's less power in our fast frequencies. So down here the picture's kind of cut off, but I don't know if you guys can see these numbers here correspond to frequency. And our key up here, the white and yellow would indicate a higher power of those frequencies, which would, there's more of those frequencies at that specific time. So an inward shift would indicate a lower frequency, so slow wave. And that's what we're seeing here. We're seeing these really slow waves and almost like it's there's no activity there. We're not seeing anything. So this would probably be, this is a hypoperfusion event here during a cardiac case. So I want everyone to pay attention to kind of this picture here. And we're going to see the effect that a 200 milligram bolus of probe would cause on the EEG. So this was during a hypertensive episode, during a cranial clipping. We can see this inward shifting, and it kind of mimics what a real event would look like. So we'll put them side by side so you guys can compare them. This is the real hyperperfusive change versus the propofol bolus here. So both causing global slowing, and one, I guess you could say real, the other is just the effect of the drug from the inhibition. Burst suppression, I'm sure you guys have heard this term before. It's often useful for neuroprotection when there's a need to reduce cerebral blood flow, or when cerebral blood flow is reduced. So it's not otherwise, it's not useful otherwise, and it can make it kind of difficult for us to monitor and call changes. So this is just an example of what burst suppression would look like here. We can see that there's activity, and then it kind of tapers off and eventually becomes isoelectric here. So one way we in the OR can rule out an anesthetic versus an actual real change is if it's global or focal. So here we can see a focal change. Again, these blue, this is left hemisphere here. And this was during a clipping, a MCA clipping. So we know that this is a real change because it's occurring in one hemisphere versus a global change in the right hemisphere as well. Evoked potentials. We stimulate nerves and we record from the periphery and the central nervous system. So we're evoking the response and then eliciting the response via electrical current, and then recording from the scalp. Some examples of some evoked potentials that we use: SSEP, the BAEP, that brainstem auditory evoked potential, the transcranial motor evoked potentials, and the visual evoked potentials. And our goal is we monitor latency, so the time it takes from stimulation, and then the time it takes to, for us to record from the electrodes on the cortex, and we're also measuring the amplitude of that signal, so the strength of it, more or less. What happened? So we can either use surface electrodes. You guys will see us either use surface electrodes, those little sticky electrodes, or we can use needles to stimulate. So we have an anode and a cathode, and then this would be where we would be delivering that stimulation, and then we would record from the scalp. This is just an example of what an SSEP would look like here. You can see this green trace here. This is baseline, and then these are the subsequent SSEPs recorded for this patient. Okay. So again, like I said, we can either use needles or stickies, and then other electrodes are placed on the body, neck, and head to detect the signal as it traverses through its tract that we're monitoring. So in an SSEP, we are monitoring the dorsal column pathway, or the dorsal column medial lemniscus pathway. You can see that pathway shown here. It's this dark blue one. And then where we place the electrodes on the scalp, the cortex is somatotopically arranged, and we place them depending on where we want to record that signal from. So I'm sure you guys have all done cases where we're doing SSEPs. You know that there's quite a bit of needles in the patient's head. So just kind of be aware of that when you're blindly reaching in there to find your IV. We would hate for someone to get stuck accidentally. And if something comes out, that's okay. We can replace it. We want to make sure we can avoid a needle stick. And if you need us to kind of come up and make sure that you guys aren't going to pull anything out, we can certainly do so, or help you hold the drape. You guys can get to your IV or whatever you need to do. So this is just kind of illustrating what each of these waves corresponds to. So this is your cortical response here. This is your cervicomedullary response, and brachial plexus. This one down here. So for the SSEPs, we try and limit up to 1 Mach of gas if medically safe. depending on what literature you read, it might give you like a MAC of 0.7 or less. Here within our group, our policy and procedure allows up to 1 MAC. And it doesn't mean you guys can't go above a MAC. If as we increase the agent, the effect it will have on our SSEPs will increase. And typically we start to see that above 1 MAC of gas. So we kind of set the threshold at 1 MAC. I know a lot of times, especially if we're trying to control pressure, we can't go below a MAC, and that's fine too. But, we want to make sure we keep the patient safe. So if we can stay at a MAC or below, that's great. If not, as long as we're able to at least have, if something's there that we can monitor, and we communicate that with the surgeon and they're aware, it should be fine for you guys to do that.
And Jonathan, we're looking at cortical potentials here, right?
Yeah, these are cortical here. These are subcords.
And I don't want to, jump ahead, but the effect of the anesthesia for the subcords, they're a little more reliable for us even at higher levels, and depending on the case, whether it's a cerebral case or a spinal case, is probably going to determine how much we're going to jump up and down.
Right. Yeah. So like Brian said, if we go back to this picture here, so this downward deflected potential you guys see here, this is the what we call a subcortical response. It's recording a couple things here. One of the nuclei in the brainstem, and then
Jonathan, we're not seeing anything. That's not. You can't see what you're pointing to.
Oh. Okay, so this right here, this downward deflecting one, this upward, this is your subcord or cervicomedullary response here. So the inhalation agents and most agents in general won't have an effect on our subcortical response. So if we have a subcord here, and you guys happen to have a high MAC, as long as we have this and it's reliable and we communicate with the surgeon and our neurologist, you guys can have a higher delivery of gas. If that's what we need to do for that case. So you can see here, this is ISO that we're giving. You can see the effect as we increase our agent. This is the expired tidal volume here. We can see that the amplitude here, it starts to decrease as we increase our agent. So this is at 1.8. It's essentially, even at 1.5, it's pretty much completely abolished. There's nothing there. And again, that's just because of the inhibition of the mechanism of your volatile agents. And over here, let's compare it to our subcord. That's the signal we were looking at the last slide. We can see that as we increase, there's really no effect on this wave here. So this is what we call a waterfall view. We can just see these are some SSEPs that we're recording, and time is here. This is at 3% of SIVO. You can see that the amplitude starts to attenuate, and essentially the signal is completely lost here.
Jonathan, why are there 4 columns there?
Yeah, so this is a great question, Brian. So we can see here US, UD, TS, TD, and then those montages next to it that I talked about that just correspond to different locations on the scalp. This is the left upper extremity. This one is the right upper extremity. This is the left lower. This is your left leg, and then this is the right lower extremity. So that's what each of these columns corresponds to. Any questions on this slide? Out of as far as which volatile agent causes the most inhibition, typically nitrous will have the largest, deleterious effect on our SSEPs here. And it varies, depending on which agent's already being delivered. A lot of times, when we switch to nitrous, we have an agent that's already on, so we kind of have that additive effect of two agents at the same time, which causes even more inhibition and can affect our signals. Okay, let's move on to motors real quick. You guys have done cases with this with motors so far? Some of you? Or we have you guys do like a TIVA anesthetic? Not yet? In the back? No? Okay, your time will come. It will. So with the motors, we're stimulating at the motor cortex, and we're recording from the distal extremities. So this is an efferent pathway, as opposed to stimulating distally and recording at the cortex. Afferently, we're doing the opposite for this pathway. So we place a couple electrodes on the scalp, and then we're going to put some electrodes in the muscles that we're monitoring, and we're going to record the compound muscle action potential post stimulation of the fibers here. So to do this, we elicit a high intensity, high stimulus train of current at the scalp, and then the muscles move in response to the stimulus, and that's what we're recording. We're recording that muscle action potential. So here's a picture. You guys can't see my mouse anymore. This is just a picture of what a motor would look like over there on the right side. So this is from the hand. This is the right hand that we're recording here, and at the top, and then the right anterior tib, and then the foot down here. So cases where we offer these procedures, any spinal case, cervical spinal case where the patient has myelopathy, cord injury, any thoracic spine procedure, we offer these to the surgeon. Intramedullary tumor resections, TVARs, which we actually just recently did one of these with Dr. Turbush in specials, so we don't do these too often here, but he might start doing these. Any sort of cerebral aneurysm cases, and a posterior fossa or foramen magnum cases. So this would be a craniotomy. So the pathway, the modality is affected by pressure, temperature, anesthesia. Low BP can cause changes. Low temps can cause changes. And therefore, our our request with you guys and the anesthesia requirement is strict. We typically will have you guys do a TIVA with no muscle relaxant. I guess I should specify here, it would be no non-depolarizing. So we can use succinylcholine. Or, you know, a lot of times we're pretty lenient and say like a defasciculating dose of non-depolarizing is fine too. And this modality is most affected by the muscle relaxant. So the surgeons that request this modality they'll typically have us do a large dose of non-depolarizing for induction and then have it taper off. Some of them will just say, you know, no neuromuscular blocker, use sucks right from the get-go. It just depends on the surgeon's preference. And then if we do use non-depolarizing agent and they don't have 404, typically we'll ask the surgeon if we can reverse, and then we'll have you guys give Sugamidex.
Jonathan, could I note here too, a lot of these cases where we're using TCMPs, especially spine cases, what will be coupled with that is pre-positioning baselines. So pretty much, you know, you guys are getting the patient intubated, getting that tube, you know, secured, and we're gonna wanna get good baselines right away. And, you know, even if you give us a small dose of rocks, sometimes you're gonna be sitting around tapping your toes for half an hour and the surgeon wanting to flip the patient because we can't get baselines. So that's why, you know, the ultra short acting relaxant up front is really important in most of these TCM-EP cases, especially the spine cases.
Test 1, 2, 3.
Okay. So as you guys know, 4 to 4 twitches can mean different things depending on where we're recording the twitches from. So over here, this is some data here. These are those motor evoked potentials. So this is the right, this is the left, and again, this is the right side, this is the left side. This is during a cervical decompression case, and the surgeon requested rock during exposure, and after it had apparently worn off 4 to 4 twitches, it took a while for the motors to come back. So we can see 4 to 4 was reported at 9:57. These are the motors that we were able to record at that time. The 4 to 4 twitches were recorded using one of your stimulators from the right at the head, and then at 1:45, these are the motors that we got here, and 4 to 4 twitches were still reported. Okay, so the pathway for the motor pathway, it's a multi-synaptic pathway. So the agents can affect motor cortex, anterior horn, or at the neuromuscular junction. Again, we prefer Tiva with no relaxant due to the fact that the motors are easily abolished with that the inhibition caused by the inhalation agents. There has been reports of being able to record a motor with low concentrations of gas, but here with our group, we in our policy is we would prefer a full TIVA if we can do that. If it's medically safe and the surgeon is okay with doing that. So we talked about delivering these high-intensity stimulus. It obviously causes the patient to respond. Essentially, when we run these motors, the patient is going to like jolt on the table. So we want to make sure we have a bite block in, a soft bite block. Our policy and procedure requires 2 soft bite blocks. A lot of times here, the CRNAs and anesthesiologists will just use one big one. You know, as long as it's big enough where the tongue is out of the way and it's not going to be bitten when we run these, that's fine. But in a perfect world, we would prefer 2, one on each side. And we can even make those for you guys too. I typically make them if there's not one made. You guys just have to place it. We can't place it. Okay. You guys have any questions about motors before we move on? No? Okay. This is just a checklist for like our alerts. I don't know if we really need to go through this, but essentially this is the workflow of what would happen anytime there was an alert. We would have the surgeon stop with their current manipulation that they're doing, assess the field for cord compression, and then perform other decompression if stenosis is present. You consider reversing correction spinal deformity. What we would do is rule out technical error or any sort of false positive on our end. We would check our leads. You know, so anytime this changes, if we think that it's not surgically related, you guys are going to see us up at the, you might see us at the head, just kind of manipulating electrodes or under the drapes. We're just trying to make sure that it's not something on our end that would lead to a false positive. And then we would, once we rule out a technical error, we would communicate with you guys just to make sure you didn't, give any anesthetic that might be affecting our data. So neuromuscular blocker, bolus as a probe. Okay, let's talk a little bit about the analgesics and the effects that they have on our signals. This would be your fentanyl, Remy, sufentanil, morphine. Typically, the effect of the opioids are less prominent than with the inhalation agents. So, it might cause a small change in our data, but it's not going to be, it's not going to have as big of an effect compared to the inhalation agents. So after the, say you guys give a bolus, we might have a transient change in amplitude, increase in latency of our cortical responses. But minimal change in SECPs and motors. Precedex, we don't mind Precedex. We think it's a good adjunct, especially for these TIVA cases. at infusion rates greater than 0.5 mics per kilo, we can run into issues with our motors. It can cause some, inhibition, and what we would see on our end is just decreases in amplitude or changes in morphology. So if we're gonna run a Precedex strip, just be kind of aware of this threshold here of 0.5, if especially if we have a high infusion of prop as well, this is probably going to cause some changes with motors. We try and avoid boluses, if we can, as a large bolus will cause inhibition and inability to record a motor potential. Ketamine, we love ketamine. This enhances our cortical SSEPs and our transcranial induced MEP amplitudes. No effect on those subcortical potentials that we saw earlier. And although we like it, it's sometimes contraindicated in cases with intracranial pathology due to increases in intracranial pressure. So, even though we like ketamine, the neurosurgeon that we're working with might not allow any sort of ketamine during that case, just because of the increase in pressure. So etomidate, same thing with ketamine, increases our amplitudes of cortical responses, and this increase is associated with myoclonus, suggesting that it's excitatory in nature. So we see our picture here. You guys can see when before they gave it, and then you can just see how amplitude increases 15 minutes after. Okay. Propofol, we talked a little bit about this already, about its inhibitory effects, and studies with TCMEPs have shown a depressive effect on amplitude and with large boluses of propofol. That's this paper here. So this paper essentially talks about it reviews false positive alerts and attributing that to large doses of propofol. Okay. So the cases, this is just a synopsis. Cases with SSEPs only, maca gas is fine, muscle relaxant is fine. You guys can use as much muscle relaxant as you want, as long as it's okay with the surgeon. We would prefer that, if you guys are going to give any bolus of prop or narcotic or ketamine, just communicate with us. We prefer no nitrous, if medically safe, and less than 50% is typically acceptable. And you can do infusions of Remy, Precedex, prop. These are fine to use with SSEP only cases. Procedures with SSEPs and EMG, such as a spine fusion, again, 1 maca gas. Typically we'll, muscle relaxant at the beginning of the procedure. Induction's fine. Oftentimes they're gonna have us you know, they're gonna have you guys redose the rock or the exposure, so you guys will give even more. We need 2 out of 4 twitches to record EMG, and we need 4 out of 4 once we do our pedicle screw testing. So, you know, if the surgeon is constantly asking for redose of rock, we might be up there just asking you guys if there's 4 twitches. We recently started monitoring train of 4 on our end from the leg. It's not quite built into our policy and procedure yet, but we are monitoring on some cases train of 4. Any cases with cranial nerve EMG, so here this would apply to like those ENT cases we do, so your thyroids, your parotids, neck dissections. We would prefer succinylcholine, or that defasciculating dose if we need to do that. But 4 out of 4 twitches is needed to record when we stimulate. Again, that's exactly what I just said here. It's the same thing, thyroids, parotids, microvascular decompressions, or an XLIF. The XLIF, this is that lateral fusion. I don't know if any of you have done one of those yet. It's a lateral lumbar fusion. During these cases, we do some stimulation as we expose. So, depending on which surgeon you're working with, whether it's Dr. Stone or Dr. Balot, they will either have you guys paralyzed or not paralyzed for these procedures. So, if anyone's worked with Dr. Balot, you guys know he loves paralytic. So, anytime you're with him, it's SSCPs only, essentially. And EMG, unlike his spine cases, EMG. Any case with when we're monitoring motors, we prefer TIVA. Again, Precedex infusions less than 0.5 mics per kilo. And we prefer, you know, no non-depolarizing muscle relaxant used throughout the procedure, unless the surgeon asks for it. You know, if they ask for it, certainly give it. And then bolus is a probe, and narcotic. We try and avoid those. And again, we need that soft bite block, so either the bilateral bite block or that a real thick one we can use. Any case with EEG, this would be an example here, would be the carotid endarterectomies, any sort of craniotomy where the surgeon requests EEG, cases in specials, anytime we're in there, we're always running EEG. So for this, we would prefer no more than a MAC gas. Trying to avoid boluses if we can, and try and avoid nitrous. Certainly at the end of the case, you know, you guys do whatever you want as far as, you know, the agent that you're using. I know a lot of you put nitrous on at the end, which is fine. This is more applicable for the, you know, during the actual surgery. The visual evoke potentials, we haven't done these here in a long time. I don't know if we ever will. These are the most sensitive out of the modalities that we do. So this would be TIVA, and essentially no boluses throughout the entire procedure for these, but I doubt we'll do any visual evoked potentials. The cases that we're monitoring the auditory pathway, you guys can do whatever you want on those cases, essentially. If it's just the brainstem auditory that we're monitoring, there's no effect on the modality with anything that you guys do. And this is just a cheat sheet that summarizes your anesthetic effect here on these two modalities. So these are the modalities that we run often here, the SSCPs and the motors. So this arrow just indicates an increase or decrease. A would be amplitude, L would be latency, or the time it takes for the signal to, the time it takes for us to record the signal. And then this plus or minus just refers to, you know, the keys down here at the bottom. You guys can see that, just the effect that it has. So the 1+ sign is a minimal effect, and then as we increase, you can see here the benzos have the largest effect on motors, and neuromuscular blockers have the largest effect. Okay, that's all I have. Do you guys have any questions? I kind of wanted to go quick. I know it was a lot of information, and probably a lot of it didn't make much sense to you guys, but in essence, I just wanted you guys to be aware of the modalities that we use and the limitations, because you know, oftentimes it's frustrating when you guys go into a case and you don't know that we're going to be in there, and then you know, we're like, oh, we can't do this, and you guys get upset with us, and you know, we want to avoid that. So. Any questions, anything?
Thank you.
Thank you.
Yeah, I'm gonna have Rachel send this to you guys. You guys can. Oh yeah.